Welcome to the International Federation of Rural Surgeons YouTube channel for doctors. Today, this is the summary of the Zoom lecture that IFRS had for rural surgeons on urology emergencies. How common are these emergencies? We have seen earlier that 4 to 5% of patients presenting to any OPD in a rural area will have urology problems. And at any given time, if there are 1 lakh population, there's about 1.5 patients with urology emergencies. If you look at it in another way, 2 to 3% of those who present to urology or general surgery OPDs will have urology emergencies. Fortunately, most of these can be tackled by general surgeons. And one other thing which needs to be noted is that ureteric colic can cause such a severe pain, which is almost as severe as labor pain. This is one of the most severe pain which is experienced by men. So what is the most common presentation or emergency? This is the retention of urine. And there are many causes for it, and which can occur in men and women. And there are some causes which are particularly specific for men, like the bladder outflow obstruction due to BPH, urethral strictures, urethritis, and sometimes even phimosis can result into retention of urine. And there are some causes which are specific for women, like prolapsed uterus, or post-stress incontinence surgery, or large pelvic masses. And some neurological problems can again cause retention in women. And there are some conditions which are common to both men and women, although they are more common in men, like calculus or small 1 or 2 centimeter size calculus in the bladder, blood clots. Then sometimes even fecal impassion and severe pain can lead to obstruction. However, the most common cause is spinal anesthesia. Very often they go into retention after spinal if they are not catheterized. A little bit more detail to what happens if there is obstruction to BPH. As you know, benign prostatic hyperplasia, the prostate keeps enlarging, and it slowly causes obstruction to the lumen, and the pressures which are necessary to start passing urine keeps increasing. And this process, although it's a slow process, sometimes the size can suddenly increase if there is a bleed inside the prostate, or if there is infarction or edema. So these things can suddenly increase the amount of obstruction and go into retention. Another frequent factor is that patients, when they postpone menstruation, for example, if they're traveling somewhere and there's no place to pass urine, they might try and hold for a longer time. And this will lead into retention. Most of the time, just passing a Foley's is sufficient. And you need to remember that since there is retention, you need to give prior antibiotics and then use plenty of lubricants and be very gentle. And at the sphincter level, you need to realize that the patients can voluntarily contract it. So when the catheter tip goes there, you need to apply gentle pressure and wait till the patient relaxes the muscle and the catheter goes in. And once you have a catheter, it's good to leave it for a couple of days, about 48 to 72 hours, and wait for all the whatever problem which caused the obstruction to settle down. The edema can settle, the infarcted tissues, again, which causes edema, can settle, and so on. And sometimes they may be able to pass urine with their trial or void. And if they're unable to do so, then it's better to put back the catheter and wait. And the temporary measure till you need to do a SPC drainage. Can be just to put in a spinal needle or any long needle and aspirate. This gives a little bit of time for the patient to wait without pain till a definitive procedure like SPC drainage could be carried out. And when you're doing a SPC, you need to remember that if there is a stricture or something like that, the urologist need to do a scopy from above. And the higher you are or the further away you're from the pubic symphysis, this will help the urologist. So you need to put it as high as possible. Again, make sure that you aspirate urine. And you can use the SPC trocar and cannula to put in a SPC. But then any block post-relief can have severe diuresis. So it's important to monitor the urine output and make sure that patient doesn't go into dehydration. Another severe problem is the loin pain, ureteric colic. Classically, it's a pain which radiates from loin to groin, and the patient keeps rolling in pain, unlike peritonitis where the patient remains still. Here, there are two things which you need to remember. One is that if there is vomiting, it means that it's an ongoing process, active process. And if there is fever, it means that there is an obstruction and infection. So if there is fever, you need to give sufficient antibiotics, do cultures, and make sure that obstruction is relieved as quickly as possible. And one should not forget the various differential diagnoses. There are many conditions as the table shows, starting from aneurysms, pneumonia, myocardial infarction, twisted ovarian cysts, appendicitis, testicular torsion, and so on. These can present similar to acute ureteric colic. And these are more dangerous, and the way to differentiate is that these processes, the pain, the intensity keeps going up and doesn't get relieved immediately. And there is no gap, it is a continuous pain. So what are the investigations that we do for ureteric colic? Probably the most basic one which is necessary is X-ray KUB. And if there is an ultrasound, that is helpful. KUB and urine microscopy is a must because they'll tell whether any WBCs and RBCs are there in the urine. And elevated DSR and C-reactive protein would indicate inflammation. So if the stone is small, then most of the stones, even up to 1 centimeter, can pass by itself. So it is worthwhile to, if the pain is not severe or settled down, to try medical treatment. You can give an alpha blocker, you can alkalinize the urine, you can give antibiotics and anti-inflammatory medicines. All these things can aid along with the diuresis or drinking a lot of water in helping the stones pass. If it doesn't help, most of the stones which pass, about 80 to 90% of them, would pass within 2 weeks. If it doesn't happen, then we can go for surgical treatment, starting with DJ stenting. Hematuria is another emergency which we encounter. Here there is, as a list shows, there's plenty of causes starting from the kidney, urothelial tumors, prostate, calculi, trauma. And the important take-home message is that any hematuria, blood either microscopic or macroscopic, or even history of hematuria, needs minimum in at least X-ray, KUB, and cystoscopy to rule out any of these pathologies. And depending on what pathology needs further treatment. And of course, one should not forget that there are medical causes for blood in the urine too. And but then the surgical causes need to be ruled out before you start looking for medical causes. And again, if the hematuria is because of trauma, the history might help sometime. Say if there is hematuria due to urethral causes, it is generally an initial hematuria because the urine collects there. And when you start passing urine, the blood comes in. If the causes are in the bladder, like when a small bladder tumor or stone or inflammation, then it is terminal hematuria because when the bladder is full, there's not much of a blood seen. And towards the end of maturation, then you have the blood. And total hematuria could indicate renal causes. And if there is a pain and dysuria, it might indicate stones. But these generalizations are not 100% this way. So it can have any combinations of types of hematuria. But any hematuria needs evaluation with at least a KUB and a cystoscopy. And one other thing very often people do is use medicines like ethamsulate or tranexamic acid for bleeding. Unfortunately, what happens is that in prostate or bladder, this instead of doing good causes further damage because most of the bleeding venous bleeding and these are controlled when the muscles collapse because they come and block the vessels. But if the muscles open, then you can see these veins which are remaining open and it will continue the bleeding. So it's good not to use any of these to prevent clot formation, which will prevent the collapse of the bladder or the prostate. And for the same reason, you need to use a 3-way Foley's catheter to irrigate and wash away any clots so that the bladder remains collapsed. And if you're in a rural area and if you have the low-cost laptop cystoscope, you can use a bug-bay electrode to have a look inside and cauterize those bleeding areas. And even if bug-bay electrode is not there, you can use an open-ended or a pusher that is used for degestenting and a guide wire to cauterize these areas. Now we come to what is called priapism or prolonged erections. There are any erection which lasts for more than 4 hours is termed priapism. And there are two types. One is ischemic, the other one is a non-ischemic. And one need to remember that irreversible damages can occur if it lasts for more than 24 hours. The reversible causes most commonly are due to intracavernous injections, papaverine injections or other things which we use for testing to see if erection is there, whether it's psychological cause for erectile dysfunction and so on. And sometimes sickle cell and leukemic infiltrates can cause these reversible erections. And irreversible causes are idiopathic most of the time. But then substance abuse and antidepressants, etc., can cause these irreversible priapism. And how do you manage it? The first thing is to put in a fairly thick needle and do aspiration. And then after aspiration, you can irrigate with sympathomimetics like epinephrine or adrenaline or phenylephrine. And these, most of the time, 95% of the time, this should suffice. But if it doesn't help, then you might need a cavernoglandular shunt. And very often the simple thing to use is a biopsy gun for creating these shunts. Penile fractures. These often occur in elderly men when they try and have sex with the younger women. And they generally present late because of the obvious reasons. And evacuation of the hematoma and suturing is all that is possible. And sometimes they're beneficial, sometimes they are not. What about acute scrotal pain? Here, the most important thing to remember is that if there is any torsion, it can be either spermatic cord or testis or the appendages, it's important to treat them as quickly as possible so that there's no damage. And sometimes just infection like epididymis or epididymoarchitis can present with severe pain. And most of the thing is better to err in the form of offering surgical treatment than waiting till irreversible damages happen. Renal trauma, fortunately, it doesn't occur commonly because the kidney is well protected. And even if it occurs, 95% of the time they can be managed conservatively. And again, if there is a need for exploration, you need to be prepared for nephrectomy, which probably may be the easier option in a rural area. And sometimes the bleeding can worsen and it can cause more damage by exploring than treating conservatively. And ureteric injuries, again, more iatrogenic than natural external trauma or any other trauma. And the important thing is to realize it as quickly as possible and immediate treatment at the time of injury rather than waiting till urinary ascites is there and peritonitis is there. And once there is sepsis and prolonged ileus and fever and so on, the prognosis is and morbidity is high and the prognosis is bad. These are the various types of treatment which can be offered. The simple way is to just suture it and put in a stent. Sometimes partial transection anastomosis may be needed. Sometimes you might need reimplantation or bore flap or a flap from the bladder. Or sometimes you might even have to take the urethra to the other side and anastomose. And very rarely, if there is a severe damage, ileal replacement. And sometimes even nephrectomy may be warranted. What about bladder rupture? This again, you need to be aware that quite often the causes can be iatrogenic after resection, because you need to realize that bladder is sort of a round organ, and when you're trying to resect, it can cause a hole and the bladder can rupture. And if there is clot and retention and the bladder expands, the tear can become large. And again, blunt trauma can occur, especially in people who are drunk, who don't have enough sensations. And again, diuretic effect of the alcohol will cause a massive distension of the bladder. And blunt injury can lead to obstruction. Here again, high index of suspicion and early treatment is warranted. The classic clinical triad is blood in the penis, difficulty to void, and suprapubic tenderness. A formal three-layer closure should suffice. And it's good to have a catheter in for a long time till healing is complete. Urethral injuries are often associated with pelvic fractures. Here again, it is good to do a SPC first. You can attempt a gentle passing of urine if there is not a total separation. And if the catheter goes in with a lot of lubrication and gentleness, then it might help the urologist quite a bit. But if it doesn't with one attempt, then the best thing is not to cause further damage. Put in a SVC and wait for 3 to 6 months and for the urologist to come and do the needful. And one more word is that urosepsis can be life-threatening. And usually it's gram-negative organisms which cause the sepsis. So you need to be very careful and aware of this and cover with proper antibiotics, third-generation cephalosporin and aminoglycosides. And if necessary, ICU treatment and inotropes, etc. And important thing is to try and have a culture done whenever it's available so that you can give the appropriate treatment. Thank you.